When an arterial blockage occurs, the clock starts instantly. Oxygen delivery stops, and downstream tissues immediately begin to suffocate. A 68-year-old male with a history of atrial fibrillation arrives in the emergency department, writhing in sudden, unrelenting abdominal pain. His vital signs are stable. When the physician presses on his abdomen, the tissue is soft and non-tender to the touch. This is acute mesenteric ischemia. It is a strictly time-is-tissue surgical emergency, carrying a mortality rate between 60 and 80%. This high mortality rate stems almost entirely from delayed clinical recognition, often occurring long before the patient reaches the operating table. To save this patient, a clinician has to override their standard diagnostic instincts. In this disease, the physical exam is deceptive, and routine labs offer a false sense of security. The defining board buzzword for this disease is pain out of proportion to physical examination. This diagram shows the intestinal wall's blood supply, branching from the outer serosa inward to the mucosa. When perfusion drops, the deep mucosa undergoes anaerobic glycolysis. It starves and sloughs off first, while the serosa remains structurally intact. The dying mucosa triggers deep visceral pain fibers, causing severe agony. Yet when a clinician presses the abdomen, their hand meets uninflamed serosa. The tissue feels soft, masking the internal catastrophe. Without rapid intervention, the ischemia progresses outward until it causes transmural infarction, the death of the entire bowel wall. By the time peritonitis, abdominal rigidity, or hematochezia appear, the window for early survival has likely closed. The physical exam is unreliable because the outermost layer of the bowel dies last, concealing the necrosis happening within. This map highlights the celiac trunk, superior mesenteric artery, and inferior mesenteric artery. Superior mesenteric artery embolism causes 50% of cases, linked to factors like atrial fibrillation. The SMA's steep downward angle acts as a funnel for clots. Alternatively, SMA thrombosis accounts for 25% of cases, occurring when an existing atherosclerotic plaque suddenly ruptures. These patients often experience intestinal angina, cramping after eating. In non-occlusive mesenteric ischemia, or NOMI, there is no physical clot. Instead, the entire vascular network narrows in severe universal vasospasm. NOMI is triggered by low-flow states like systemic shock or heavy vasopressors. The bowel is also vulnerable at watershed points, the splenic flexure and rectosigmoid junction, which lose perfusion first when pressure drops. Venous thrombosis causes the remaining 5% of cases, typically seen in patients with hypercoagulable states or portal hypertension. Managing AMI requires addressing 4 distinct mechanical and hemodynamic failures, as each mechanism dictates a different clinical response. When a clinician suspects ischemia, the natural impulse is to wait for laboratory confirmation. This printout illustrates why lactate levels are misleading. While unexplained metabolic acidosis is a warning sign, a normal lactate is common in the disease's early stages. Waiting for lactate to rise often means waiting for the bowel to become irreversibly necrotic. A second common error is the impulse to order basic imaging, like an X-ray or ultrasound. These tests have essentially zero utility in diagnosing AMI and only consume the patient's remaining window of viability. CT angiography is the absolute gold standard and appropriate first-line choice. It provides immediate, high-contrast visibility of the vascular network. The high sensitivity of a CTA allows the clinician to instantly differentiate between a physical occlusion and widespread vasospasm. Because time is tissue, choosing any imaging modality other than CTA is a distraction that directly threatens patient survival. All suspected cases require immediate resuscitation, aggressive IV fluids, bowel rest, and broad-spectrum antibiotics. This decision tree shows how treatment bifurcates based on a mechanism identified by the CTA. The left occlusive branch highlights myemi, requiring a mechanical fix to restore flow. The patient requires urgent surgical embolectomy, stenting, or bypass. Conversely, if the CTA shows non-occlusive mesenteric ischemia, the strategy is entirely different. Systemic vasopressors must be stopped immediately. Administering these drugs during NOMI further constricts the vessels and worsens the ischemia. The medical strategy is to infuse vasodilators, like papaverine, directly into the SMA to force the vessels to open. Regardless of the cause, every mechanism has a universal fail state, the discovery of gangrenous bowel. Once necrosis occurs, Emergent exploratory laparotomy and bowel resection are mandatory, leaving the patient at high risk for short bowel syndrome. The diagnosis must dictate the management plan. Applying a surgical embolectomy to a medical vasospasm is just as fatal as the ischemia itself. Returning to the 68-year-old patient from earlier, screaming in pain, yet presenting a soft abdomen, this checklist represents the successful intervention. The clinician intercepts the disaster, connecting atrial fibrillation to the pain, disregarding the benign exam, and acting instantly. The diagnostic rule is clear. Suspect acute mesenteric ischemia in every elderly patient with sudden abdominal pain and cardiovascular risk factors. Diagnostic speed, bypassing inconclusive labs and low-tier imaging, is the single greatest determinant of survival. In the mesenteric circulation, time equals tissue. Trust the patient's pain, doubt the physical exam, and proceed directly to CTA.